morning, everyone. I'm going to discuss hemostasis in pediatric cardiac surgery. Just a quick recap of the process of hemostasis. Primary hemostasis, which involves vasoconstriction and platelet plug formation. Secondary hemostasis involves coagulation system activation and fibrin clot formation, while tertiary hemostasis involves cross-linking of fibrin strands and fibrinolysis. There's a difference in coagulation process in adults and in the neonates. The platelet count and von Willebrand factor, which are responsible for primary hemostasis, the platelet counts are same in both neonates and adult, while von Willebrand factor is higher in concentration in neonates. The factor 2, 7, 9, 10, 11 and 12 are less in neonates in comparison to adult, while the fibrinogen is same, factor 8 and von Willebrand factor is higher in neonates, while all the anticoagulant factors are comparatively less except alpha 2 microglobulin, and for fibrinolysis the plasminogen concentration is less. And another is maturational factor. Coagulation system is quantitatively and qualitatively immature through at least first year of life, and both coagulation factors and inhibitors are affected. Baseline coagulation defect exists in many children with congenital heart defect, probably because of hepatic hypoperfusion or hypoxia. Now 58% of children with non-cyanotic defects, they have coagulation abnormalities, while 71% with cyanotic defects have the coagulation abnormalities. Children whose hematocrit exceed 50% have significantly worse baseline coagulation deficiency than those whose hematocrits are less than 50%. Cyanotic children older than 3 years have worse abnormalities than younger cyanotic children. Children with cardiac lesion involving systolic flow abnormalities are at increased risk of developing qualitative platelet dysfunction than those with diastolic flow abnormalities. The another factor responsible is exposure to CPB circuit. Activation of contact factors and hemodilation that occurs at commencement of CPB, and post CPB platelet adhesion is decreased and aggregation is also diminished due to depletion of content of platelet granules. Now I'm going to discuss the blood management for neonates and children undergoing cardiac surgery according to the NETA guidelines, which was published into 2019 in JCVA. Now what are the different strategies for the blood conservation? Starting from preoperative period, it involves autologous blood donation and erythropoietin therapy. Now what are the indications of autologous blood donation? It is done in children with more than 3 years of age and weight more than 15 kg. So we can obtain the blood from femoral or external jugular vein under sedation, 10 ml per kg per phlebotomy, and the volume is replaced with 0.9% saline or colloid. There should be an interval of 3 to 4 weeks before another donation can be made, and last donation may be as late as 1 week before surgery. The autologous blood's shelf life is 3 weeks with CPDA solution and 6 weeks with cryopreservation. Disadvantage is that every donation should be succeeded by erythropoietin therapy, and it is difficult to do it with poor venous access. Now erythropoietin therapy may be used in children with low pre-op hemoglobin as a part of autologous blood donation. Doses 300 microgram per kg 1 week before autologous donation or surgery. Then supplemental iron, vitamins, folic acid and B12 are given at the time of recombinant human erythropoietin therapy. Anemic patients benefit more than non-anemic patients. Side effects of erythropoietin therapy are hypertension and flu-like syndrome. Now, what are the intraoperative strategies? Monitoring lines and sampling volume. Repeated attempts at the same site while taking the cannulas, while securing the lines should be avoided. In case of failed puncture, prompt compression of puncture site should be done, and whenever possible, a change in the site of vascular access and a possible change of hands are advisable. limiting frequent flushing of invasive lines because it will prevent hemodilution, and sampling volume should be restricted to minimum, that is less than 1 ml. Use of double stopcock technique decreases hemodilution and conserves blood. So this is a double stopcock technique. Now what is the second strategy is acute normovolemic hemodilution. Patient should have a baseline hematocrit of more than 30%, that is a prerequisite. We can do it through arterial or central line, and volume to be drawn, it should not be more than 10 to 15% of the blood volume while replacing the fluid deficit with either crystalloid or colloid. Anticoagulation should be done either with CPDA or it can be withdrawn after administration of heparin. Advantages are that diluted blood is lost during surgery and post-operatively fresh whole blood is transfused. It can also be transfused on CPB to maintain target hematocrit. Then antifibrinolytics. Initiation of fibrinolysis begins with skin incision. Administration of these drugs prior to skin incision result in significant reduction of fibrinolysis, platelet dysfunction and blood loss than administration after CPB and protamine infusion. Loading dose of tranexamic acid is 10 to 30 mg per kg and infusion is 10 mg per kg per hour, while epsilon aminocapric acid loading dose is 40 mg per kg and infusion is 30 mg per kg per hour. Then retrograde autologous priming, it completely or partially replaces prime volume of the pump. It takes about 4 to 5 minutes before commencing CPB. By displacing 50% of the prime volume with retrograde autologous priming, hematocrit is reduced by 50% only versus 75% if we are not doing RAP. To counteract transient fall in mean arterial pressure, small boluses of phenylephrine can be given. NATA guidelines recommend addition of FFP to CPB prime in neonates who are less than 30 days undergoing cardiac surgery. However, because of lack of evidence, same recommendations can't be made for infants and children. Colloid should be preferred over crystalloid for clear priming in children. Now, miniature extracorporeal circuit are half as long as conventional CPBs and they decrease the interaction between blood and artificial surface. It includes downsizing the arterial lines and venous line. Arterial line filters has been eliminated from certain oxygenator use self-venting technology, and oxygenators like baby effects decreases prime volume and hemodilution. Venous reservoir is elevated to the level of RA and venous return is maintained using vacuum assisted venous drainage. Microplegia, that's another technique to deliver microplegia where blood is diverted from arterial line of CPB circuit through the roller pump. The cardioplegia with high potassium concentration is delivered in blood by syringe pump. Cardioplegia to blood ratio is 1:60, which is achieved by maintaining infusion rate of roller pump and that of syringe pump. Microplegia prevents hemodilution, especially on repeated delivery, decreases the tendency for tissue edema, provide better myocardial protection, higher oxygen delivery and negligible fluid balance of cardioplegia. Induction dose will be 10 to 30 ml per kg and maintenance around 5 to 10 ml per kg. Redosing interval vary from 15 to 35 minutes. Ultrafiltration increases hematocrit and post-operative blood loss after pediatric cardiac surgery. NATA guidelines recommend cuff or more than 10 minutes of muff for neonates or infants. Now, what are the post-operative strategies? Point of care tests and transfusion algorithms should be used. For transfusion, antifibrinolytics, recombinant factor 7A and reducing blood sampling in post-operative period. What are the point of care tests? In pediatric patient, there is more than 50% decrease in coagulation factors at initiation of CPB and fibrinogen level may fall below 1 gram per liter. So, thrombocytopenia occur in 60% of the cases post CPB, while qualitative platelet defects occurs in 10 to 33%, while coagulation factor deficiency occur in 30% of cases and hypofibrinogenemia in 9%. So these are point of care tests. We can even use in ICU, ACT, platelet count, PT, APTT, INR, viscoelastic tests like TEG, ROTEM, Sonum clot, and qualitative platelet function test. Whole blood less than 48 hours old better limits post CPB blood loss in children less than 2 years of age. It is attributed to the better functioning platelet in whole blood. So if there's first we have to neutralize heparin. If if bleeding continues, we should give platelets. If still the bleeding continues, we can go with cryoprecipitate, and then we must raise fibrinogen level. FFP fails to raise the level of fibrinogen. So when using component therapy to treat post CPB coagulopathy in children, platelet transfusion followed by cryoprecipitate seems the better approach to restore hemostasis. So PT, if it is more than 1.5 times the control, we should give FFP, which is 10 to 15 ml per kg. APTT more than 2 times, again FFP 10 to 15 ml per kg. Platelet, if less than 50,000, we can give 10 ml per kg of platelet concentrate. And fibrinogen, if it is less than 0.8 to 1 unit, we can give 1 unit for every 10 kg. NATA guidelines recommend that FFP should be considered for treating hypofibrinogenemia in bleeding neonates and children only when cryoprecipitate or fibrinogen concentrates are not available. So transfusion trigger. During blood transfusion in children, following points shall be considered: that there is no uniform cutoff value to define restrictive and liberal transfusion practices. It is logical to have higher hematocrit in children with cyanosis or single ventricle physiology in comparison to acyanotic children. Restricted transfusion strategy is safe under strict monitoring of end organ oxygenation parameters. A goal hematocrit of 30 to 35% should be achieved by blood conservation rather than transfusion whenever possible. In children with hemodynamic instability, restrictive strategies is of questionable value. NATA guidelines recommend post-op transfusion trigger of 7 to 8 in acyanotic and 9 in cyanotic cardiac children with clinical signs suggestive of symptomatic anemia. So this is an algorithm that first we should, if heparin is present, we should give protamine 0.5 to 1 mg per kg. If bleeding stop, that is good. If bleeding persist, then we should evaluate coagulation profile. If there's a less fibrinogen, we should give cryoprecipitate. If platelets are less, we should give 10 ml per kg of platelet concentrate. If APTT or PT is 1.5 times the normal, we suspect coagulation factor deficiency and should give FFP of 10 ml per kg, and then repeat the coagulation profile. If it is normal, it's okay. If it persists, then we should suspect excessive fibrinolysis oozing from multiple sites, including venous puncture site. We can give tranexamic acid or Amicard. If still the bleeding persists, empiric therapy based on risk factor. Now, recombinant factor 7/8 is not FDA approved for control of surgery bleeding, right? So, NATA guidelines recommend against the use to treat coagulopathy in children. Then PCC, again, NATA guidelines recommend against using PCC in pediatric cardiac surgery unless it's a part of clinical trial. And we must reduce blood sampling and flushing in the post-operative period. Thank you.